So we're now going to discuss some of the challenges that our three nations have in managing pressure damage. So my first question to all three nations, so do you have specific challenges in communication and documentation between the hospital and acute setting? So I think I'll start off with what happens in Wales. So we've produced a pressure damage passport that's meant to follow the patients on their journey. However, there have been lots of challenges when patients are transferred between wards or discharged home, and the document's often lost. And also not all health boards are using the passport. So if the patient's transferred to a different health board, then the documentation may not go with them. However, COVID has highlighted that we need better IT structure. And in Wales, we're using a digital record for wounds. And so that's going to be across community and acute. And this includes our Once for Wales reporting documentation. So it means that we'll have a little bit of consistency across acute and community across the whole of Wales. However, there is issues because, of course, this doesn't communicate with GPs. And also, if we've got a patient within the nursing home, then obviously it doesn't communicate there. So we do have some issues in that sort of sense. But I think listening to Catherine's talk, we all have that issue with correct grading. Everyone has that. And we do have some inconsistencies with reporting, especially with moisture damage and mucosal pressure damage. So I'm sure that that's something similar that's across all three nations. So I'm now going to pass over to Catherine, and she can comment on what's happening in Scotland and what sort of challenges you have. Over to you, Catherine.
Yeah, it is a challenge in my health board, and definitely some of the other health boards in Scotland. We've got different systems completely for the hospital and the community, and in fact, we've actually got some of my treatment room nurses, the GP and the doctor surgeries, they have their own records and notes. So that if maybe in the treatment room, you've got certain records and notes, and then the community has a community system, and then the hospital has a hospital system. So you get a patient in from the community into hospital with pressure damage. You're not able to see look at their wound chart, for example. You're not able to look at that. You're not able to find a care plan. You're then needing to phone the district nurses and say, and then obviously they're out on visits and you leave a message and then they phone you back and then you're finished your shift. And there's a real difficulty in getting that information between the health professionals. If you've got family members, and I think sounds like the ones from, Locksmith's story, they would have probably been on that. And if they'd had the passport like what you've got, they'd have brought that in and you'd have had those things. But, there's people who don't have family, people's family aren't involved or what have you. And often you go into hospital in a rush and you don't have the time to think, I'll bring that booklet or whatever. So yeah, we really have issues. And then on discharge, the nurses in the hospital, they keep all of their records. We've got computerized wound charts. It's all in the computer system. And so in order to get the care plan into the community, you actually have to ask them to do an extra piece of work when they're really, really busy as it is, and write out a paper form to then put out with the patient so that the traditional nurses actually get it. Or again, to make some kind of phone call handover, which with timings is just a really difficult thing to do. So we really do need to improve that. It's something that needs to be focused and prioritized, definitely. And then again, like I said, with our grading and just an understanding of, if you grade something incorrectly as say a 3, and actually when they get back into the community nurse is saying, well, this is a 4, you don't know, did it get worse? Or did you just have it not graded correctly in the first place? And these things, they really matter. And it's an ongoing challenge that we've got. For really bad ones, the tissue viability team will get involved and will be that link, and I'm very in the lucky position that I do cover both. So I'm able to be that link person, but there's a lot of times when you're not able to be. And with the smaller wounds, we're not involved in every wound. So how do you do it? And I suppose that's we've not yet got a solution, have we?
Yeah, I think that's the same. So Laxmi, do you have similar challenges in England?
Absolutely. And I have to echo both yourself and Catherine's challenges are the same thing we face. And if anything, as you know, Catherine was saying, communication between acute and the community, very often the message gets in, but by the time the nurses are back to give you that message, the ward are not available to receive, or that staff who requested for it have now gone off shift. So our community nursing where I work have now gone paperless, which means all our wound cares, our documentation are all on electronic patient record. There's no paper document that the family member can take in with them to the hospital to show this is what the nurses have been doing. So, and equally, and this is similar to most community setting across England, our services don't have the same electronic patient record. Our nursing home is still on paper. We are completely on electronic. Our GP has got completely different electronic system, and the neighboring acute trusts work completely on a different system to us. So not all 4 systems will communicate with each other. So if you do want to know what has been done for that patient, there is that breakdown in community. And very often, you know, and I will echo exactly what Catherine has said, it's miscommunication about the classification of the pressure ulcers, which we might know that actually, yes, it was an unstageable in the community, but by the time it's gone to hospital, it might have, you know, debrided and now exposed the accuracy, which is a 4, but it's that difference. So, you know, you can't, and these things, it generate a load of unnecessary paperwork where, you know, if all 4 nations work together, hopefully one day this will be fixed.
Yeah, we should all be on the same hymn sheet with it, really. If we all could see each other's records like you can with you know, like the DVLA, you know, you can anywhere, or the NMC, anyone can log in and see one system and everyone can get that information. But yeah, we're not there, are we?
No, and definitely, I think we can all see the benefits of a one system that speaks to everybody, because we know that is one of the frustrations. I think another thing that I'm sure that you're all seeing at the moment is patients with long waits in ambulances to get into A&E, and that early skin inspection when they go from one environment to another environment is really important, because otherwise we don't know if patients are developing harm. We don't know when they developed it, and you know, should we be thinking about these ambulance patients when we look at preventative strategies?
Definitely. And like say, it's the early inspection. I've come across patients with horrendous wounds, maybe 2 or 3 days into their admission, and nobody can tell me
when it started.
Did they come in like that? Yeah. When they came in, what was it? And you're really having to play detective a lot. I don't know about you guys, but I think as a tissue viability nurse, you're also a detective. And
definitely.
It's difficult, isn't it? But yeah, I think the ambulance is definitely somewhere where we could be picking up on these people.
But equally, I will add to that, because if a patient is so acutely unwell that they need a hospital admission from the community, you know, we have to acknowledge that they are unwell. So the skin is the most vulnerable at that point. So if they have already got a pressure ulcer, say category 3 pressure ulcer, but they are unwell for something else that they need it, and they're waiting for 8 hours for an ambulance to get to the acute, that category can deteriorate in a matter of just that waiting time.
Definitely.
And the district nurse may have seen the patient that same morning and call an ambulance for the patient. Family's waiting for her and they saw a cat 3, but by the time it gets to Catherine there, the category 3 might have deteriorated further. And this is where having that communication is really important, because then, you know, as TVN, as trust, we can communicate to say, this is what I saw. You log into my system, you can see what the wound was like this morning. But unfortunately, by the time she's come to you, it's deteriorated rapidly.
Yes, you almost need a RAG system, a red, amber, green, so that, you know, when they have their assessment before they go in, people are highlighting that these patients are high risk and need urgent pressure relief, really.
Yeah.
Really interesting discussions. I think we'll move on to the next one for our nations now. So many of our complex patients with complex needs and comorbidities are managed by care packages delivered by care assistants. These care assistants are in a key position to spot early pressure damage and also raise concerns early. So we can put early preventative strategies in place. So do you think there's enough emphasis on training and education on pressure ulcer prevention for carers working for local authority or care agencies? So here in Wales, you know, the education for non-qualified carers does vary, and I'm sure that you're all going to say the same thing. So Social Care Wales has introduced a standardised qualification for new carers called the All Wales Induction Forum. And Social Care Wales also state there should have, you know, any carer should have this NVQ or QCF or City and Guilds qualification. There's a small element in these qualifications on pressure damage, but it's not massive. Within my role at the moment, part of my role is at teaching and education. So we have been commissioned by some local health authority or local authorities that recognise that educating carers in pressure ulcer prevention is really important. So we are so excited about that. But again, it's not across the board, and it's very hit and miss what education they get. So, you know, we also know that when we're learning from a pressure ulcer incident, are we actually passing this on to the social carers as well? Because of course, they may be involved in the care somewhere across the line as well. So how does this vary? First of all, I'm going to pass firstly to Laxmi in England. What do you feel about it?
So I completely agree with this point, Kirsty. And one thing we have to remember, the carers who are employed by social services to deliver care in the patient home are very often, you know, not qualified carers, like with, I would say, an NVQ sometime. They've got basic knowledge. And these care agencies, some of them are private, so they will invest in their staff having good moving and handling first as mandatory, but topics like pressure ulcer prevention are their least concern. So the most important, they'll train their carers to be able to use a hoist, a sliding sheet to move the patient safely, but there's no such thing as educating them on pressure ulcer prevention. So I'm going to speak on my local area only, but I know it doesn't happen across many other settings. So in my area, we actually identify a very high significant pressure ulcer, which were developed in the community. And these patients were not known to any of our community settings like healthcare professional within our trust. So we took that back to the quality assurance team, and we actually did as like an audit kind of an QI perspective, quality improvement perspective, we introduced a pressure ulcer prevention training for all home care agency over 6 months. And we did it via Zoom, so they could reach it out from wherever you want. So having the backup of the local authority on that and the quality assurance team, which is a part of the commissioning group, the CCG, as we call them, it was really important because they mandated these care homes for all the carers to have that training. And we saw an improvement in skincare when these carers, after having the training, were picking up the phone and calling the GP to say, Mrs. So-and-so has got redness, we need barrier cream. Whereas prior to this 6-month education, there was nothing. And we will only get a referral from the GP when Mrs. So-and-so has already developed a pressure ulcer. But as I say, it's only happening in my local area. It's not something that we could sustain because, you know, resources with increase in clinical activities, there's not something we can maintain long term. But I think if we look at it from a quality improvement point of view, if the local authority can invest in there or get the home care agency to make it part of their mandatory, just having like an hour of pressure ulcer prevention as part of these staff induction, it will make a difference in patient care.
That's really interesting, Laxmi, because it's definitely a missed opportunity. And I think in Wales, they're trying to integrate health and social care, so that will definitely improve things. So Catherine, how are things in Scotland? What challenges do you have with social care?
Being more on the acute side, this is something which I'm not going to say I'm an expert on, especially not for the whole of Scotland, definitely not. In terms of locally, we haven't been involved specifically in doing any training with home carers. Most of them are private care agencies who are kind of taken on board or like paid through the council or what have you, but they're mostly, you know, they're a lot of private care agencies. What we have done though, which came through with COVID, was we were given and all trusts were given funding from the government for care homes, and obviously looking at reduced pressure ulcers and, you know, the care of patients in care homes. And the funding was used for a care home team. So we've got a team of tissue viability nurses specifically for the care homes that we have. We've got over 100 care homes in our local trust, and they're hugely care, you know, mostly carers, a lot of carers in there, and they have just been getting specific training made from the care home team. They've been going out to the care homes, giving the training. We've got a lot of virtual training and a lot of support, and we're seeing huge improvements, and there was a real need for it. And it's been quite an exciting time for us. It's the first sort of just about a year now that we've had the care home team in place, and we've really been working with the carers in that sense. But yeah, in terms of the home carers, we haven't unfortunately been massively involved, and it sounds like what Locksmith's doing is brilliant, and hopefully it's something that more places can be doing.
Yes, and I think that integration and working together between health and social is a very important part of that.
Absolutely.
So finally, going to move on to our last question for the three nations. So what are the specific issues regarding to discharge of a patient with pressure damage, or somebody who's at risk of pressure damage, from hospital to community, or vice versa? So for me, it goes back to what Catherine mentioned earlier about the categorization, the reporting, and the identifying correctly that it's pressure damage, not moisture or something else. Another challenge that we have is the difference in equipment that's provided and who will provide it. So across Wales, it varies hugely. In my previous role in the health board, we had the same provider for beds and mattresses, whether you were hospital or community. So that did help a lot with continuity of care, making sure that the patients had the same equipment wherever they were going. However, we did have issues if patients went to a different health board or even to a nursing home. So we can't guarantee the efficacy of the equipment they use there. And also who would supply the equipment. We have that problem as well sometimes. And we also have problems in community, especially with patients or relatives thinking they're being very helpful and purchasing equipment. And sometimes it's suboptimal. And in some cases, it's led to the development of pressure damage. So, these are specific problems that we have. But I think the main thing is about that reporting and that communication between hospital and community, definitely. So I'm going to throw it back to Catherine. What sort of issues do you have or within your own area of work?
Yeah, very similar, unfortunately. We've had patients with significant pressure damage. In fact, we had a gentleman who his air mattress deflated at home, and he lay for a couple of days on a flat mattress, had really significant, terrible pressure ulcers all down his right hand side. And he was then, once we got him sort of medically well, he was then delayed discharge because we were unable to get a high enough spec of mattress for him in place for his discharge, because you've got to, it's different providers, it's different ways to go through, there's different availability. And yeah, that's a real challenge. And there is delayed discharges, and you can get that pressure. Okay, we need beds, we're very, very busy. We can't really be holding on to patients for equipment. But on the other hand, you have to really fight and say, well, we can't send them out without equipment. So yeah, that's an issue, definitely. Sourcing equipment, and equipment just being the same. If somebody's getting discharged and they don't have specialist advice, for example, a ward patient, and the nurse on the ward saying, oh, well, they're on X cushion. If they don't know what's like for like, they don't know, okay, well, this is the same standard, this can do the same level of pressure, category of pressure ulcer as this. And that's also really hard. There's gazillions of different names and brands, and everyone's making a cushion and everyone's making a mattress, and how do you know what's like for like when you don't have that? So that is a challenge. And yeah, like I said, the grading making sure that's accurate, making sure it's handed over, making sure that actually someone's getting discharged with a new wound, that they are actually know that they're going to get picked up by the community, or who's going to pick them up. Other issues that we had were in terms of patients, they got a lot stricter, understandably, about patients trying to really encourage people to go to the treatment rooms. And where, you know, a lot of people thinking, oh, well, they've got pressure, also they've got to, the district nurses, and actually it's about re-educating, saying actually that patient is mobile, they could get to the treatment room, and giving them that guidance towards discharge to the treatment room, because otherwise, again, you're getting more delayed care. So yeah, I'd say that's an issue. And an issue that we have in hospital and community, which is one of my bugbears, is people on these beautiful, high-spec, dynamic mattresses, and then sitting out all day on a rock hard chair with no cushion. And that's just, you think, if you need a mattress, then you need a cushion. And if you don't need the mattress, you know, then let's step down. And that's again what Luxmi said. We don't step down quite as quick as we step up, and we don't match our mattresses to our cushions, or the other way around, and that drives me mad.
Yeah, I think that's a problem we have as well, and people are a bit frightened, they're risk averse to step down, especially if the patient's going out to the community. They feel they've got to be on this very high specification mattress.
Yeah.
So Luxmi, what sort of problems do you have?
I think both of you have said most of my challenges, but from a community perspective, I would also add what we see in the community, and you might not see that a lot in the acute, but patients switching off the air equipment because of cost of energy.
Oh yes, that's
so yes, we do have issues with, you know, having not the same mattresses, and they will come out in the community say, I want the same equipment I had in the acute, but because we're a different contract, we can't provide that. And as a result, you know, there's always that, you know, issues and discontentment. Why can't you give me that equipment? This is all same for us across England, where I work in my local area, but we have seen a lot of people, and I think sometimes we are guilty of what we do as well, because we're going to say to Mrs. So-and-so, we're going to see you 3 times a week, say Monday, Wednesday, Friday. So they know the district nurse will come at certain time and certain day, and the equipment remains switched off when they know the nurses won't be in. And we have been picking that up, because why is the wound deteriorating when everything should be in place? And then it just turn up when, you know, you randomly change visit because of staffing, which we know we have seen during COVID, especially where we had to move diaries around to do visit different days. And that's where these issues has been flagged. So how can we, when we're providing equipment to the patient, to the relatives, and don't forget, most of them are elderly, and if they're, as you saw in my case today, if they're reducing package of care from 4 times a day to twice a day due to financial, you know, reasons, how can we educate them to let them know that actually the equipment we are giving to you is not going to use all of your electricity bill for that month? It's about, you know, really making sure that companies are supporting us with the appropriate information, so our nurses at ground level can give that information to the patient, to the relatives, so they understand that it's not going to impact on them financially. But also, I completely agree with the step down, because we feel, oh my God, we've got a pin to protect. So the patient has healed, and okay, yeah, she has a heel cat-free pressure ulcer, and she's now walking around the house everywhere, but we're leaving that air mattress in when she's sitting out a whole day to watch TV. Is it not easier or better to give her an air cushion for prevention, knowing that she can now self-reposition and she's not even using the bed daytime? So it's about empowering our staff to make that decision confidently. And as you say, it's different contracts across different health board. So it's one equipment doesn't fit all this, you know, the areas, the settings, care homes, residential home. Who gives air equipment to them? I know for us, the residential home, the district nurses support them with ordering equipment when they develop, you know, we have got an equipment decision tree making, but in the nursing home, they have to purchase their own. How do you know they meet the spec? How do you know they are at that high level that it needs to be? And I think on my final point on this one will be patient buying online. I'm not going to mention any online platform here, but yes, we do see that all the time. And then they're getting all sorts of cushions, all sorts of equipment, devices, and sometimes some donuts ring. And when you go in there, the first day there's nothing. The next time you visit, there's a nice ring of purple discoloration around there, which already caused deep tissue damage. So it's about educating as well. So hopefully, you know, with this watch party, we can make a bit more public awareness.
Thank you, Lakshmi. I think it's been a really interesting discussion. And I think we found out that across the 3 nations, that our problems are very, very similar. So I would like to thank you all for listening to our watch party, and thank you to Lakshmi and Catherine for their insightful presentations, and also to Flen for sponsoring this watch party.